Please be advised that anything you say or type into the chat might be captured for the public recording that gets posted to our website. Dr. Castro-Marin, looks like enough members are here for quorum. Do you want to call the meeting to order, please?
Yeah, so we'll go ahead and call the meeting to order on Tuesday, August 30th at 1 p.m. This is a standing committee special meeting for protocols, medications, and devices, T3G update. Shelley, can you start us off with the roll call, please?
All right. Amber Rice.
Present.
Erin O'Connor. Is Erin O'Connor on the call? Brian Smith.
Present.
Chester Key.
Present.
Bronco Castro-Marin.
Here.
Garth Gamer. Garth, you want to do a mic check or audio check? I don't see him anymore. Heather Miller. Heather, are you still on the call?
Yes, I'm still here, sorry.
Thank you. Jason Johnson. Josh Gaither.
I'm here.
Thank you. Mark Hansen.
I'm here.
Matt Shaw said he was not able to attend. Paul Dabrowski. Philip Hannon. And Shari Brand said she was not able to attend. Garth, did you join? I need Garth to join for my 8th.
I saw him just join. Dr. O'Connor did contact me. She is caught up with some patients on call, so she will not be able to join us.
I'm on. I'm sorry I'm late.
Okay, great. We do have 8. So we do have 4.
All right. And I apologize, Shelley. I don't think I have a copy of the agenda, so I'm kind of using the screen here. We'll go ahead and begin our discussion and action items. So may I have a motion to discuss, amend, and approve T3G updates?
So moved, Brian.
All right, and I just want to apologize, you guys. I made a mistake on the last agenda. There is one more from Paramedic Shaw for airway management.
Okay. If I can get a second, we can go ahead and open for discussion.
Second.
Thank you, Dr. Gamer. Mr. Shaw,
Paramedic Shaw was not able to attend, so I scroll down.
Sorry, did you say Mr. Shaw's not on the call today to guide us through this one?
That's correct. He's not.
So I guess the first issue is that it looks like the boundaries of the page are exceeding the page margins, right?
Yeah, I see that too.
Well, why don't we do this? Why don't we skip this one for now and then just go on with the ones that are available with representatives available to walk us through, and we can always circle back and do that if no one has any objections.
All right, I'll pull up the general medicine seizure.
And I believe is general medicine, Dr. Gaither.
Correct.
Okay. I'll make my screen bigger here. So Shelley, I'll let you pan through this. There are not a lot of substantive changes in this seizure protocol, as best I recall. A few clarifying points, but no substantive changes. And I'm going to pull up my notes that I made as I went along. I just didn't have those on a separate page, so didn't know I was up. So give me 30 seconds here.
So Shelley, maybe if you can just scroll through while Dr. Gaither's looking at his notes. I think the only thing that I saw that was added in the red, and this was some discussion at NASEMSO and in talking to the obstetricians, was to really focus on magnesium first for suspected eclampsia. So that would be the only thing to consider is, does that confuse that if we add that in, because that would conflict with the OB guideline.
Yeah, I'll give you my opinion and why it got on here. I'm totally will defer to the expertise of the group. Magnesium is not a quick drug. It takes at least 5 minutes, and depending on where you look, 5 to 15 minutes to give. And although it does work, don't get me wrong, I would hate to be wrong. Waiting for 15 minutes to give MAG to a patient who's pregnant, only to find out they have a seizure disorder, and that magnesium would not have been what worked. So that was my thought, but.
So I think one way to address that would be, because certainly I agree, we don't want to miss that. And the benzo should be given IM per kind of our Rampart study. You know, traditionally, that really what came from that study is if unclear etiology, may administer IM benzo at the same time as IV magnesium. What do you think about that verbiage?
Totally fine by me.
That's Brian. I have a question. Did you say benzo IM when you have an IV in place then to give the MAG, or is that really a push to do that before you have the IV, which might require a little clarification in here?
I think that's a fair point, Brian. And another reason why this is very confusing at the field level, right? We certainly, I mean, our standard of care when you come to a seizing patient is to give the benzo and then try to get an IV. There's no doubt about it. This kind of alters your standard of care. And I understand that eclampsia is a bad disease and only treated with MAG, not benzos. But again, we hate to be wrong.
So maybe if unclear etiology, may consider simultaneous administration.
Sure.
Do that.
Works for me.
Me too.
Yeah, I agree.
Yeah.
We did have quite a bit of discussion about this at the NASEMSO level, but and I think as just the point is, you don't want to get it wrong, but if we have the treatment definitely is the MAG with these scenarios. So, Shelley, are you able to make that? I'm trying to in the Google Doc. I may have to reopen it. It's not letting me make edits. Let me maybe try reopening it to see what the final verbiage would show.
Gail, did you VPN in from your location?
I'm sorry, can you say that again?
Sure. Did you use the VPN?
No.
You might need to do that. Sorry.
Looks like. I think this is where the training piece, you know, unless you get two IVs, you wouldn't be able to run them in together. That's why I kind of thought you do have the option of IM Versed as you're trying to get your IV in to give your magnesium.
Yeah, I think the beauty to this language currently is it allows you to do either one. I believe that we allow IV administration of benzos if it's already in place. Looking above, I see that's not the case actually. We do in our local guidelines. We generally say if an IV is already in place, give half the dose of your midazolam above. That's not in this one. I guess it is midazolam. I'm sorry, midazolam 0.1 mg per kg IV. So I think you'd be fine leaving this vague. I think it's the.
So this right here in red would be the new verbiage.
The only thing I would change is instead of the benzodiazepine, a benzodiazepine. And
There's
then,
a comment from Chris Ramos that deserves an attention there.
that sentence may give benzo first and follow with with magnesium goes away.
Yes.
Perfect.
And just for the record, Mr. Ramos pointed out that according to Micromedics, midazolam and magnesium are compatible.
Okay, I think that's all I had on this one. Anything else on the seizure one? All right, then I'll go ahead and move on to the next one, which I believe is shock.
Do we want to go ahead and approve that one?
Yeah, any further discussion here? Otherwise, we'll go ahead and take a vote to approve. All of those who approve the seizure updates as discussed, say aye.
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 Any opposed? Any abstentions? All right, that motion carries.
Is hypoglycemia okay to go to next?
Sorry, sure. I just was doing a different order.
Which one do you want to do next?
No, it's purely whichever one's in the documents. I'm trying to scroll along separately. I will get there, I promise. There it is. I found it. Just some wording changes there to be more generalized at the top, validated stroke store instead of naming the one.
Excuse me.
Giving a dose range on that glucose there. A little kind of almost informational stuff, but clarifying some treat and release things for who qualifies for what. The D10 dose there, I just putting in preferred. Everything else stays the same. That's it.
And just, it looks like we have 1 ml per kilo, so we'll just need to delete one of those. And we should put that in the pediatric side as well, the preferred for D10. I guess it doesn't matter, D10, we're going to dilute anyhow. Just disregard. And then just another R in there.
Anything else?
Hi, it's Brian.
Go ahead.
On that, that treat and release verbiage in there, in the treat and refer, which is more, I think, what the terminology is for those who are doing that. When you look at the number of agencies in Arizona that are participating in the treat and refer program, they're very, very, very small in relation to the total number of EMS agencies in Arizona. And I wonder if by having this included in there, there may be some inference that people might be treating and referring or treating and releasing or referring under other situations when they're not really participating in the program, because it's a very special deal. I wonder if we should really have that in there and be making that inference.
So Brian, I'll take a stab at that. And again, of course, defer to the wisdom of the group. We do this locally as a treat and release protocol. And I did use that term on purpose. It is not treat and refer, right? We're not sending them anywhere else. This is purely meant to be an individual who has hypoglycemia after taking a short-acting insulin and not eating. So we do have a protocol locally where for those very unique patients, they wake up, they're back to normal, they have a sandwich, and they stay at home. That is a treat and release protocol. It's not billed for, nor does it believe I fall under the treat and refer program for the state.
So the patient is not refusing, then you're saying that it's okay for them to stay home? They're not signing any refusals or anything?
Correct.
We have a question from Dr. Zeidler.
Hey, sorry, I got a question on the adult IV dosing. If you guys can scroll to that for a second. You say you're going to administer 25 grams IV/IO, but then underneath it, when you say milliliters, you kind of give a range where you say 1 ml per kilo. Should that not be the 250 mLs to be consistent with the 25 grams listed above?
Very good catch. Thank you. I would propose kind of a compromise. The reason it says 25 grams is that's how it comes. It's a 25 grams and 250 cc bag. And the evidence-based dosing for that is actually the 1 cc per kilogram with a max dose of 250. And that using that lower dose has been shown to decrease the rates of rebound hypoglycemia after pre-hospital glucose administration. So maybe the compromise would be dextrose, 25 grams in 250 cc's IVIO. Would that help clarify?
Yeah, I just see confusion where it says 25 grams, but then the weight of my patient is less than that. And how much do I give?
Yep, I agree 100%. Thank you.
So
Thank you.
that top line with the bolded comment, the bolded label of dextrose, really that entire line is just dedicated to identify dextrose, what concentration, and then the actual dose to be administered is the line below that.
Right, but then we have another bullet below that gives a different concentration, a D50 concentration.
Oh yeah, I see. Because the D50
So-
is still 25 grams.
Yeah, I mean, I think 25 is like a max dose, right? So
Correct.
you could sort of refer to that as a max dose, but we list it as options in 2 different concentrations here.
So if we remove the 25 grams IV/IO out of the word dextrose, will that make it clear?
I think so.
There you go. Yeah.
We just need to reassign the IVIO route somewhere else.
And I believe.
So we can just do that in the subsequent lines where it says D10 and D50.
Yeah, it would actually kind of help our dash problem there anyways. So D10 IVIO dash.
Mhm.
Yeah. Well, it looks a little cleaner.
And then same thing with the D50 there. In front of the dash. There you go. And if we can, there you go. Yeah. And while we're at the adjustment there on the right hand side, aside from moving the pediatric bear logo, there looks like there's some funny underscoring on the D10. And then is that pediatric dextrose numbering making sense as well then? The way it's shown there?
So are we still leaving that 25 gram after the dextrose on the adult?
I'm good removing it. Make it look the same.
Shelley, did you hear we're going to remove the 25 grams next to dextrose on the left?
All right.
All right. How does that look to everybody?
That stuff looks fine. I'm still troubled by the street release thing. I'll have a comment in a second when we're ready to go on.
So before we move on, Shelley, sorry if you could scroll back down. So does everybody understand it then on the left for adults that the max is 25 gram dose or with either concentration?
I think we do need a little clarification because when I look at this, now I see the pediatric dose. We have grams per kilo, which used to max out at the 25 grams. But we teach people to dose at the mLs per kilo. So I think the dosing should be mLs per kilo, but I don't know that we should necessarily remove the 25 grams from next to the dextrose.
All right, so Gail, you're saying put back the 25 grams next to the dextrose under adult, is that right?
That's my thought, yes.
And then so that way the reader will see that if they use D10 or D50, the desired dose is 25 grams.
And we can say max. I mean, that, because I think that's to Josh's point is,
Yeah.
you know, when we trained on the D10, we really trained a lot on infuse it until they wake up.
Yeah.
So
Yeah, so my question goes back to, if I give 1 ml per kilo and they're 80 kilos, I'm giving 80 mLs. That's not 25 grams. So do we need a dosing range?
It's really about a max, right? It's not really a range that we're getting at. It's about a max. So maybe under the line where the cursor is shown right now, we add dextrose and then just put in brackets max 25 grams. Would that be enough? Would that make sense?
Yeah, I just need something so that if, I'm only giving 80 milliliters, which is what, less than 25 grams, that somebody doesn't say, well, I'm supposed to give 25 grams.
Right. Yeah, so that's what I'm suggesting is that if in that top line where it says dextrose bold and underlined, if we just put in brackets max 25 grams. Yeah, so there was a comment about what if 25 grams is not enough? The box below that stipulates that you can repeat dextrose.
Sorry, so one more thing. So we say repeat as needed under the D10 dosing, but not under the D50 dosing. Is that how we want it to read?
No, it's a whole separate box below that says you can repeat dose of dextrose. It doesn't specify which concentration.
No, but we do list it between the D10 and the D50. There's a dark colored box that
Oh, I
says
see.
it's needed.
I see. Well, we could just move that repeat as needed line below both of those. Or you can say we're back where we were above, max 25 grams, comma, repeat as needed up there.
Should that be max single dose?
Yes, max single dose, yeah. There we go. And then we can save, we can cut that line. There you go. Yeah. And then you'll need to put the or up next to preferred. There you go. How does that look? Any other comments on this before we move on to Brian's next question? Okay.
So it's still a repeat concern about this concept that I just wonder, in light of a recent statute, HB 2431, that there could be an implication that treating and releasing people is saying you're okay, you don't need to go to the hospital, and that there's an implication that that becomes a diagnosis, and then we end up contrary to that new statute.
Hey, Brian, this is Amber. To my knowledge, the statute specifically excludes protocols in which this is outlined in a protocol that it's excluded from the statute. So just as treat and refer, if you have a protocol that they follow that's evidence-based, that there's safety, evidence of safety, which is why this was created, that would not lead them to be subject to telling someone or counseling them out of going to the hospital, because this is an evidence-based protocol.
But doesn't it say a recognized treat and refer program? When then the question becomes, what is that? Are you in the state's treat and refer program? I can go pull it up real quick if we want to check that language, but I think it says a recognized treat and refer program. So what does that mean? Can any medical director do anything and it becomes recognized, or does it have to be part of the state's treat and refer program?
This gamer here, I've got it right here, Brian. Except as part of a specific alternate destination or treat and refer program that includes quality management and comprehensive medical direction oversight. And the preamble to that is it's clause B2. It's you may not do either of the following, and number 2 is counsel a patient to decline emergency medical services transportation except as part of a specific alternate destination or treat and refer program. So I was just going to ask Dr. Gaither if he thought that if he would accept the word refer in there instead of release.
So, this is one of those unintended consequences. This is I'm going to stress, the only treat and release guideline that we have evidence to support its safety for, right? This is a true as evidence-based guideline as you get. Are these criteria for not transporting a patient with hypoglycemia after taking a short-acting insulin. And this is not treat and refer. We're not referring this patient back to their primary care physician. We're referring them, or we're releasing them to stay at home, because assumably under these criteria, an individual simply forgot to eat, right? They are now eating and they've fixed their problem. They don't need to follow up with their doctor. They don't need to follow up with anybody. It was an accident. Of course, we can easily follow this, but I will use my agency as an example. We do have a treat and release guideline for hypoglycemia. We are not a recognized treat and refer agency, and I don't see that changing anytime in the near future. So up to the group, I'll defer to you all, but it's a shame to see evidence-based guidelines be thrown into the trash can.
Well, I know, but somebody decided to pursue that statute, and I think the way it was just read implies that we can't counsel people not to go, which is what you're saying you're doing. So in this case, to me, the issue becomes, does the statute override that or not? And can we put somebody in a bind somewhere along the way by having this implication in here if that's going to be the case?
Brian, this is Amber again. definitely wholeheartedly disagree that this would be not allowed by that statute. There is nothing in that statute that says that you have to be a treat and refer agency to have an alternate destination protocol, or a different type of protocol. It says that you cannot counsel them out of transport, except if you have a protocolized way to do it. And we've created an evidence-based protocol to be able to allow paramedics to be able to make this decision.
This is Jason. I completely agree. I think the evidence is there and we should stick with what the evidence shows. And I don't think that the statutes restrict us in any way.
This is Franco. It also bears mentioning that there is a clause A that talks about when an EMCT shall contact the base hospital consistent with local protocols and practice guidelines if the patient is not to be transported. It seems like the spirit of that clause would cover something like this as well. Does anyone else have any comments here?
I just think the best way to not do harm to a patient is to leave the sentence in as is. And I don't think there'll be confusion. If a treat and refer program knows they're a treat and refer program, and if they don't, if they're not, they are aware of that too.
Any other comments overall for this page? Then can we go ahead and put this to a vote to accept the hypoglycemia page with changes as outlined? All of those in favor say aye.
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 Any opposed?
Nay.
Any abstentions? All right, the motion carries.
All right, Dr. Gaither, which one next?
Totally up to you. I think the next one in the sequence is the hyperglycemia.
All right.
So we'll start the conversation out with this one doesn't exist for anyone else. And if you look at the care, it's really a fluid bolus and then hyperkalemia care, which is interesting. So I didn't offer up much other than either we eliminate this altogether, which would be my personal vote, or just put a maximum on the fluid bolus. Some people live at 300, 350, and I don't know.
I think this one does specify symptoms though. So it says if your sugar is this and you have symptoms, so of dehydration, vomiting, altered level of consciousness. But I agree a max should be there because for longer transport times, you wouldn't necessarily want to give them 4 liters.
Yeah, I think the other, and just to throw it out there, the other topic of discussion, and this applies mostly to kids, but less so, increasing so with adults, is a lot of our crit care folks really would prefer to hold on the big fluid boluses. They don't do that as much as they used to, at least down here.
And I think we did have the lower volume for kids because of that. So I think the kids were 10 mLs per kilo versus 20 mLs. Do they do a lower fluid bolus than that?
No, but I think that ours maxes at 30 per kilo though for both adults and children, which would be quite a lot for a child in DKA.
Yeah, so that's why I think where you have the red under the adult max 2 liters and then potentially take off that 30 mLs per kilo.
That would be okay.
So I'm removing the 20 mils per kilo. Is that correct?
What was your question, Shelley?
I was just confirming, you want me to remove 20 mils per kilo?
No, below, in the box below where it says max of 30, because we've sort of redefined the maxes.
Oh. So end the sentence that after fluid bolus?
No, just delete the whole line.
Any other comments on this page? I guess the first issue is there anybody in agreement to consider removing this page? All right, so then can we?
Amber,
Yeah, go ahead.
I'd be okay removing it. I feel like the symptoms that we're treating are mostly those that are in other protocols already, but I mean, I would definitely defer to the group, but I would not be opposed to removing this one.
One question I have is that if we do remove it, do we know, can we get a reminder whether or not all of that hyperkalemia treatment information is listed elsewhere? Because that has major implications across the document. I just can't recall offhand if it appears anywhere else or if other pages, refer to this page. I just can't remember.
I don't think other pages refer to this one. This does come from NASEMSO, so it is one of the NASEMSO guidelines, and we've tried to kind of adopt those. I do see EMS crews saying if I have someone who's got a sugar that's critically high and they're altered, but not necessarily vomiting, like they want to give fluids, what protocol can I give them fluids under? So I think that's kind of where this guideline does give them that option to treat.
And the same way, this is Jason. That's where we kind of use it as is, they're like, well, can I give fluids? They're not septic, but they have high sugars. What should I do? And this gives them the go ahead for that.
All right. I don't think we necessarily need to put it to a vote, given that Amber and Josh were open to the temperature in the room, and so it sounds like more would be in favor to keep it at this time. Why don't we go ahead and put it to a vote then to accept the changes as follows, or changes as explained. All of those in favor say aye.
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 All those opposed? Any abstentions? Okay, the motion carries. Thank you.
Do you want to do nausea vomiting next?
Okay. nausea and vomiting. Sorry, I scrolled back up to look at the other question. I made no changes.
All right, then, Shelley, does it matter if we vote on this since there's no changes?
Yeah, let's do a updated collective agreement on current content.
Okay, all those in favor with the current content as showed with no substantive changes, say aye.
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 Any opposed? Any abstentions? All right, that motion carries.
Hi, it's Brian. I did go confirm that in the current BFBT PEA asystole guidelines, it does have reference to hyperkalemia and treatment.
Thank you. All right, looks like the next page is shock.
I know this looks like a lot, but it's actually not. Just simplified the top one. Just clarified the fluid bolus. I wasn't quite sure why there was a max on here. Generally, what we tend to do is reevaluate at an interval, so I think we just clarified that language. And then the bottom was just clarifying and adding in push dose epi.
Do we not show the instructions on how to mix the push dose epi on this page?
No, the push dose epi, Franco, we did in the central region. That was after the last TTTG update. So I think the push dose epi would be new to this, to the state guidelines. But I think that was a good point that we would definitely want to add that verbiage, I think.
And unfortunately, it looks like we're exceeding the page surface area there as well.
Yeah, it's only because I kept the scratched out language. Once you delete it, I think it'll all fit.
Okay, all right. Well, yeah, so then probably outside of the scope of this meeting, if we could go ahead and commit to adding the push dose epi instructions where appropriate.
Shelley, could you show the top of the document again when you get done with that? Okay.
The top part.
Yeah, I wanted to take a peek at the top part again. In the bottom where we refer to a map of 65, does everybody use a map, or do we want to also add in a lower limit systolic blood pressure? I'm okay with either, but.
I think that's a good point. I don't know that many EMS providers only look at the map. They often are going to look at their systolic pressure.
So where would that fit, Amber, down below there?
Where we have pressors listed to keep a map greater than 65, I would just say maybe add in or a systolic blood pressure greater than 90 or something like that to be consistent with the rest of our.
Yeah, we'd have to take pediatrics into consideration unless we split the box, and so we'll have to get creative with that wording. I think that's why the map works well here.
Well, we still have different map goals for different ages, right?
Yeah, that's right.
You'll still have problems with peds with that map list.
Yeah.
Yeah, I mean, we'd still have to have a separate list, but systolic blood pressure, at least you could say the regular age-based cutoff for systolic blood pressure, which would be more helpful for at least the pediatrics.
Yeah. All right, shall we, Gail, would it be sufficient to just kind of put comments in there to take a look at that offline?
I think we would need to at least vote in some numbers. We can work in the formatting piece offline, but if there's critical factors that we need the group to vote on, I think this group just needs to decide on that piece. We can do a hyperlink to some push dose epi instructions, so that's something we can show and bring forward, but
Dr. Zeidler, is there an efficient way to kind of outline some targets that would be pediatrics friendly there?
Nothing really simple that I can think of. Do we still have a vital signs table that we could link to? I can't remember if we have that in state documents or not.
Don't we have one in the sepsis guideline? Is this sepsis or shock? I can't remember which one are we looking at.
Sepsis is on the next page. We can just look at that. And
Yeah. Because the sepsis one I thought had box, but
Yeah, under sepsis, it has the box for the heart rate and the respiratory rate, but not blood pressure, I don't believe. Oh yeah, they have a blood pressure too.
The display is the sepsis box. Now we're back on shock.
And the only thing that comes to mind for the sake of time is leave map greater than 65 and then just say for adults. And then say, or see pediatric table, and then link to a reference.
You still should probably have that or systolic greater than 90.
Yeah.
So I don't, just a comment. I can't remember the last time EMS crews started pressors on a child. There's very few. I'm trying to think of a situation in which a pressor would be indicated over fluid. Could this be something we just limit to adults?
I like the idea of limiting it to adults because personally, if you're going to be starting them on pressors, I'd want some online medical direction before they went down that road.
As I think through it, I mean, anaphylaxis, they'd use the IM epi, so they're getting pressors IM. I'm hard pressed to think of anything else that would require a pressor for vasogenic shock in the pre-hospital child.
Was there anything in the NASEMSO guidelines that address that, Josh?
It's been 6 months since I looked, so I would be lying if I said I knew. But when I went through this, this didn't jump out at me. So.
Mm-hmm. So I've got it pulled up here. It basically it talks about the adult vital sign criteria, pediatric physiologic targets, which are very complex and not helpful. It talks about 5th percentile for age, for systolic blood pressure, and then the rest were exam findings of presence of distal pulses, skin perfusion, and cap refill less than 2 seconds with improving mental status. And then vasopressors are all defined with no age comments at all.
the epi does have by kilo. It lists 10 kilo, 20 kilo, 30 kilo.
Oh, I see. There we go. Child. Yeah. Yeah. So it implies that there are, yeah. So they're implying that they would use epinephrine there. Well, so I guess the first question is, so there is information on the SEMSO to include at least epinephrine, specifically in children. It doesn't comment on the dopamine or norepinephrine, but it does give weight-based doses for both. So I guess the first question to the group is, how do we feel about splitting this and just counting all of this as adults? And for pediatrics, we could put something like a call for online medical direction.
Yeah, I mean, I think Josh is right. Personally, I think that I don't know how comfortable I would feel with a paramedic dosing pressors in a very small child.
I agree. That's one where I'd really want to be involved, or one of my colleagues be involved with that decision making.
All right, so I suggest we put this to an up or down vote then. But before we do, I guess the question is, what is the solution? It seems to me at first blush the solution would be do a mid-page split, kind of like we do on the SMR page, where we put all of this current information under the adult side on the left, and on the right we just put if unresponsive to IV fluids or cardiogenic shock, et cetera, call for online medical direction and stop there. Is that reasonable? Alternatively, we can put down, there is no recommendation currently for vasopressor support in children, or some alternate language there.
Yeah, I like that.
I mean, the one thing to consider, the central region has had the push dose epi specifically for adults and peds now for 2 years, I believe. And I would venture to guess that many EM physicians answering a patch phone would have to go look up the dosing and mixing of that. So it's just something to consider. Sometimes when you have that available, I think emphasizing the fluid bolus is key. But with the push dose epi, that's very specific with instructions on how to mix it, and the dosing, which is pretty small, it seems like it's been used in the central region pretty successfully. I don't have data on the number of pediatric cases at all, so that's just, saying that, but we have not heard of any adverse events or complaints from hospitals.
Well, I was just looking in the chat. It looks like Chris Ramos had said vasopressors never initiated by EMS for patients coming to PCH ED since he started in 2015.
Well, if nobody's opposed to it, I guess we should go ahead and just put this to a vote to move the agenda along. All those in favor?
Hi, it's Brian.
Yeah, go ahead, Brian.
Real quick, could we take out that for adults then on that section and get this or systolic greater than 90 in there before we do this?
So remove for adults and put down or systolic blood pressure greater than 90.
Right, because if we split it up, we don't need the for adults in there if we're going to split it up onto the two boxes.
Correct.
Thank you.
All right. So all of those in favor of splitting this box to only allow this content to show on the adult half, and then on the pediatric half, vasopressor support will be effectively deleted. All those in favor for that change, say aye.
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 Any opposed? Any abstentions? All right, so yeah, Shelley, I'll ask that we probably do that offline then. As far as for the pediatric side, my proposal is to just say, copy the language about for shock unresponsive to IV fluids, call medical direction.
All right, I'll make that edit offline.
Any other changes? All right, right, so all those in favor of changing the shock algorithm as shown with the changes as mentioned, say aye.
I,
Aye.
All those opposed, say nay. Any abstentions? All right, the motion carries. Thank you. All right, we're on to sepsis, it looks like.
Yep, no changes here except for the two things at the bottom. Then I'll
Any-
give my commentary on the IO. I would hate to put an IO in somebody and bolus them 20 cc's per kilogram through an IO. That would hurt a lot.
Okay.
One small formatting thing at the very top, in the includes, feedback from EMS in the central region was just for severe sepsis for the definition that it reads boxes 1 plus box 2 plus 3. So instead of the comma, and, that it's indicating that you need to have each of those. So instead of the commas, just a plus sign. So just the plus sign, Shelley. So instead of, here I can make it.
They just started vacuuming outside the screw line in, so I'm gonna mute myself.
All right, I will. Perfect.
All right, any other comments on the sepsis page? All those in favor of approving this with the changes as shown, say aye.
I,
Aye.
Aye.
Any opposed? Excuse me. Any abstentions? All right, the motion carries.
Amber, which one do you want to start with?
Amber, you there?
Yeah, sorry, I was having trouble unmuting. Whatever you have at the top, Shelley, is fine. I'm trying to just run down the list.
I have the CCR table, but it doesn't really fit on the page very well.
Oh, yeah. I had some comments on this one. Hold on, let me pull my actual notes so that I can see both at the same time. Go back up. So for the CCR one, my comments on these generally for the top two diagrams, for the first one specifically, my recommendation is to remove reference to all the different types of CPR that are in here. These tend to make reference to like 3 or 4 different quote unquote types of CPR. I mean, chest compressions are chest compressions and they should always be minimally interrupted. So my recommendation is to remove any reference to any other type of CPR to avoid confusion. So I would just say bystander CPR. And then at the very top where it lists different types of CPR, just say, we can call it minimally interrupted, but we also call it CCR up here. And
Do we even need it, Amber? I guess that's the question.
Like no, I don't think we need any of it. I mean, I just think it all should be CPR. But I mean, if someone's like particularly married to one, I could make the argument for having one. But we often have providers sort of making distinctions between what they would call it traditional ACLS. And so really this is all ACLS. There's nothing different about it. We're just not stopping chest compressions. So it's not really different. It's all just CPR, and they're all pretty much the same guidelines.
And I think I see Shelley typing in that this is kind of going back many years from the original version Dr. Bob put together, and then we kind of try to update it. But this is actually an image that we can't edit. So the question would be, do we need this, or do we need to create another version? So do we
I have another version if you want one. It's very similar to this, but
this version is not editable.
right.
I don't
and
think
I
so.
have one that's the same thing, just without the CCR, MICR terminology on it. That is editable. I'd have to
Can
send
we
it over.
Can we put a pin in that question then and just agree that we'll do away with this image, and if there's a suitable replacement, Amber, you can bring that forward at a later time?
Yeah, I think that's totally fine. And then if you scroll down more, Shelley, also right here. So if you look here, it says chest compressions 100 a minute. So I think much of this is very out of date, as Gail said. So if we're going to get rid of it, I won't make too many more comments on it, but the rate and the depth are different now. And the other thing I would say is that if adequate uninterrupted bystander chest compressions are provided, again, we've started to not to recommend that line of thinking, because either way, they're going to get chest compressions before you get the monitor hooked up and turned on. So I can send out as we sort of move forward, if I get done with mine, I can pull it up and send it over to Shelley once we get through the rest of mine. But so I guess we could just.
Can I maybe make a suggestion that we just take a vote on whether or not to delete this version, since it is quite dated?
Sure. All of those in favor of deleting this current outdated version, say aye.
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 All those opposed, say nay. Any abstentions? All right, the motion carries to delete this image.
And then for the next one, I had a couple of comments in here. Let me find it. One of them was in the post-resuscitation box, just to prevent hyperventilation.
Where are you, Amber? I'm sorry.
In the very bottom right corner, return of spontaneous circulation, ensure patent airway, keep SpO2 greater than 94, monitor end-tidal CO2, and I would say keep, prevent hyperventilation or overventilation, whatever terminology you favor, but.
So hold on, go up one, up to the monitor and tidal CO2. There you go. Yeah, I would just go for hyperventilation, I guess.
Yeah, prevent hyperventilation.
And then that'll require some reformatting the boxes there just a little bit.
Right.
Yeah.
Anything else?
In your box, the oxygenation box, I can't read the bottom line of that. It says 1 breath every.
Oh yeah, we've gone over that.
I don't know if we need to move it, but I can't read what it says. Actually, I can go back and look at my version, I guess. Every 6 seconds. That's fine. That does list a rate of respiration of 10 breaths per minute in a less than 8-year-old child. which I'm personally fine with. I prefer that verbiage. I just wanted to point that out to folks. Because it is different than what the new PALS recommendations are, which are definitely questionable. But as long as everyone's okay with that, I just wanted to point it out. And that's all I have in this one.
So my question, Shelley, if you could scroll back up to the diagram portion of this page. So Gail, didn't this diagram replace the one we just voted to remove that's in landscape view?
So this one, Amber, looks, we had asked everyone to look at what was in the Central Arizona regional ones in addition to the current TTTGs, just because the TTTGs hadn't been implemented in many other parts of the state outside of the Central region who had kind of adopted them. So there was some, quite a bit of changes the Central region made over the years as they've tried to teach and utilize them. So that's why you're seeing kind of a combination here of the two.
Yeah, so Amber, just to point out that you're going to bring forward what you have in terms of a diagram showing flow of the resuscitation. This looking at now is what we did here in the Central Arizona region.
Right. And the other one doesn't really have a sort of decision tree in it. It's more of a sort of overview of the resuscitation. This one's so they're in my mind very different. I can see them both being useful, but yeah, I can see the reason for having both.
All right, and then there's Shelley. There's some formatting hiccups there. Right in the center of the page, that blue oval that says "Rhythm Check is shockable." For some reason, the arrow to the left has fallen off, and then also one layer below, the arrow to the right, or the arrow to the left of the green box is now half gone as well. I'm not sure what's going on with the formatting there, but it looks like it needs some cleanup. So I guess what we'll table for now, everyone, is to take a look at Amber's product, compare against this product, which is the product that Central Arizona came up with. And my sense is use one, unless Gail has any other thoughts.
I thought I heard Amber saying that they both have kind of a little bit different format for different ways to view it. So.
Okay, so just adopt them.
That was, unless I misunderstood you, Amber.
Say that again. I'm sorry.
I thought you were referring to bringing the version that you guys used to replace the old Wabro version, but in addition to this one.
I don't know that I have one that looks exactly like this. I'm trying to think
not this one. So the one above, slide above.
Yeah, exactly. So I have one that looks like the slide above that's been updated. And then this one is obviously the sort of flow diagram, decision tree, round by round analysis.
Do you feel that they're complementary, or are they fairly redundant?
I don't know. They're somewhat redundant, but.
Okay. Well, I guess
my 2 cents, at least for my agency, having the horizontal vertical diagram really helps them visualize what the timeline is for a resuscitation. So at least for my crews, they like that horizontal flow line, but yeah, I'm good either way.
Let me pull them up really. I think I probably have both, but let's get through. I don't know what you guys want to do time-wise. If you give me a second, I can pull them up, but.
Hi, it's Brian. I have a couple of things.
Mm-hmm.
And I guess it depends on what other kind of formatting ends up here. It shows down here epi, not a complete word with a complete order, and it says amio, not a complete word with a complete order. The other thing is it's not breaking down who's doing those. So AMTs aren't going to have either. And I can't remember if amio was in the I-99 or not. I'd have to go back and look at that. Does it say down here?
No, and that wasn't.
It doesn't break out who's doing what in there.
Yeah, and we didn't have that in the original Barbara version either, Brian. So going back, I think 15 years, it was kind of the educational piece to go along, because even the slide above didn't delineate EMT, AMT, EMTI, or paramedic skills. So that's not necessarily a new thing in regards to the cardiac arrest, kind of the flow sheet format.
Amber, do you want to present your screen, or are you emailing it to me?
I can share my screen. Give me just a second here. So where are we? Too many windows open here. So share screen. So if I, can you guys see this or no?
Yes.
The document? So
Yeah.
this is the flow sheet that we currently use, and it breaks it down just sort of in a timeline. This is the sort of top to bottom, with the post-Ross care on the side. And then the updated version of the other one got cut off on here, but probably just because I formatted it wrong when I printed it, but looks like this. So similar, but just updated. So those are
So
the
you-
two that I have.
You know, on that horizontal view, you don't show supraglottic airway.
It's right here. Well, non-rebreather nasal cannula, and then here, definitive airway. And that's, we just list that as either supraglottic or not. Educationally, you know, but when COVID came, this became non-rebreather plus nasal cannula or supraglottic. So we could definitely add that there.
Okay.
But we were doing the passive oxygenation, and then the sort of timeline, the sort of, you must have your airway by this point is after our 4th round,
Got it.
if not already done.
Mm-hmm.
And then we don't list specific dosing in here because we use this one for the dosing, and we basically pulled all the dosing out into the bottom and then just listed the timeline.
Yeah.
I mean, they're not terribly different, but.
Yeah, these are great. Yeah, these are really great pages. I have to say I'm pretty impressed. It's great work, you guys. Gail, is there a way to kind of break this out, just for the sake of time, and to allow the committee to analyze this a little bit more? Because in my mind, it would ideally, we would just adopt one of these, and rather than having multiple flow charts showing 90% or more of the same information.
I think to vote on that, we could certainly table this and come back to give the committees more time to review, but we would have to table that, and which we absolutely can do. So if people need more time to review it, the cleanest thing would be to make sure we table it so we come back and have the public comment for discussion.
Yeah, I would certainly move to table this, because this is obviously, you know, as about important a protocol as we have. And so I think this warrants some more sidebar conversation.
Yeah, I'm okay either way.
Is anyone opposed to that? All right, then yeah, so let's go ahead and move to sidebar. Amber, can I ask for you to email that to Shelley for wide distribution to this committee, and then we'll circle back?
Yeah, absolutely.
Thank you.
If I can ask one question while we're on this topic, because it'll come up again. Do you all still want 3 doses of epi?
for adults, I'm still okay with that. That's how we're still doing it.
Okay.
Are you guys
Yeah,
stopping it?
Yeah, the only reason I ask, I think Amber's audio may have cut out, is that the protocol Amber just showed you only has 2. We've only been doing 2 for the last 3 or 4 years. So, but we can easily add in another one. Amber just have to add that in before she sends it out.
Yeah. Yeah, absolutely.
Wow, thank you guys for that. No, that's extra work for you, so thank you so much.
Okay, Shelley, what's our next one then?
So now we just have the protocol page for cardiac arrest, age 8 and older.
Oh yeah. So in this one, I think most of our comments are kind of in here. So at the top that lists an exclusion for patients with cardiac arrest due to hypothermia. So I don't know why we would exclude them from our cardiac arrest protocol. I don't know if there's any history to that, but I definitely would perform cardiac arrest treatment on hypothermic patients or hypothermic patients potentially. I'm not sure why they were eliminated. There isn't any other specific hypothermic protocol.
There is in this,
But not that outlines cardiac arrest management though, that I'm aware of.
Yeah.
I mean, I think the educational point is that your therapies might not work if they're below 30 degrees, but
Yeah, your point is well made. So you're proposed removing that line?
yeah, just remove that as an exclusion, that even if they're hypothermic, that they would still get management for cardiac arrest.
Is everybody else okay with that?
Yeah, I think, one of the things that when the Central Region adopted these, recognizing that there started to be multiple different cardiac arrest algorithms, that was very confusing and kind of took, followed along with what you guys did in Southern Arizona, Amber, which was to essentially create a cardiac arrest guideline for all ages outside of the neonate. And it's, and made it into a single guideline where you really highlight the, where there is a difference in resuscitation, your joules or your medication dosing. So, this current version of the TTTG for entities that have tried to implement it, it's been very hard to do because there were so many versions.
If we go up a little bit, Shelley, sorry, to the top of the edits. So for this one, I think what we have found in doing education and quality improvement work on cardiac arrest calls is that there's a little bit of confusion about when to use continuous chest compressions with passive oxygenation versus when to immediately start ventilation. I think that's confusing to some folks. We simplified that in our guideline to say that those that have a witness arrest with a presumed cardiac etiology, that we would do the continuous chest compressions on them and provide passive oxygenation. If there was some sort of non-cardiac etiology or respiratory cause, or the arrest was unwitnessed and there was an unknown downtime, then then those victims should get some sort of ventilation. And so I just clarified that in there. And then again, erase the line, if arrest witnessed by EMS or adequate bystander CPR, immediately perform rapid rhythm analysis. I don't know that that's a necessary statement because normally we're already 100 compressions in before the defibrillator's ready to be charged up. So we're already sort of priming the pump, as it were. So I just think it's an unnecessary bunch of words. And then again, I think it's just somewhat confusing to folks when to do immediately rhythm defibrillation and when not to. So I think it's easier just to say, start chest compressions immediately, and when you get your monitor on, perform your rapid rhythm check. And then further down, added the line attempts. Oh, sorry, too far, Shelley. There we go. Attempts should be made to prevent avoidable interruptions. And then at 8 minutes, begin positive pressure ventilation, if not already started, basically. And then further down, Shelley. And then for Torsades, magnesium.
Were we missing that language there earlier?
I don't know what it's, I think it just said, yeah, there wasn't anything to clarify when to give it. It just was listed under lidocaine. So I just added a line about Torsades or polymorphic VT.
Got it.
And then did we have sodium bicarb here? I don't know why that one's red.
Yeah, I don't think.
I think it's, was it in there? I can't remember if we had bicarb. I don't know why that's in there.
Yeah, I don't know that any of our protocols have had that for TCA overdose at all.
Does anyone still carry bicarb?
Yes.
So it's the one indication for sodium bicarb. I mean, I would never ever use it, but I don't know in what other situation you might use it. But I'm also fine taking this one out. I think this was just from Nisemso.
Got it.
That must be why I put it in, because I can't think of any other reason why I would have written that, to be honest. But I'm fine leaving it out. I think it was a Nisemso thing.
Yeah. Does anyone object to having that line removed for consistency? All right, Shelley, can we go ahead and remove that line then, please?
Yeah, it's in Nisemso stuff. That's why I put it in there. And the only other question I had highlighted this just for a comment. If findings of hyperkalemia are present, administer IV fluids. I didn't know if we can clarify what that means. Because I'm not exactly sure what that means.
If ECG finding, because that hyperkalemia is bolded because it takes you to a summary in an appendix of the ECG findings of hyperkalemia explained.
Yeah, but during cardiac arrest, are we going to see EKG findings of hyperkalemia? In general?
And Amber, I think to your point, the central region did update that, which could still be further updated to if findings of or concern for, with really probably in cardiac arrest, it should be really more concerns for. So you've got someone who missed their dialysis. You know what I mean? So I think that might fix it. If concerns for hyperkalemia.
Okay. Okay.
Because yes,
all right, that makes more sense to me.
Yes, that was absolutely pulled forward.
Okay. All right, that's all I had for this one.
scroll through again.
Any other questions on this? We'll go ahead and move to a vote. All those in favor of accepting the changes to the cardiac arrest age 8 and older as shown, say aye.
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 Any opposed? Any abstentions? Okay, the motion carries. All right, so we're on pediatric cardiac arrest. Did someone else have this one, Amber?
No, that was me. Sorry. I had my
Okay.
mute on again. Yeah, no significant changes here. If you, other than the, immediately perform rhythm analysis change. If you scroll down, I just added verbiage to allow for folks that want to do asynchronous ventilations. So we have 30 to 2 listed, 15 to 2, but there's obviously also the option to do asynchronous ventilations. And that was pretty much the only other change.
Any questions or comments on this page? If not, we'll go ahead and move to a vote. All those in favor of approving cardiac arrest for pediatric age less than 8.
It's Brian real quick. Sorry.
Sorry, go ahead, Brian.
Down at the bottom, that hyperkalemia thing again, since this is pediatric arrest, should we make that back like adults if concerned for hyperkalemia?
Thank you. Good catch.
I don't know about the fluid statement in this one. I don't think we have that in adults, do we? Administer fluids in cardiac arrest for hyperkalemia?
Yeah, we do. It was in the adults as well.
Oh, that's interesting. I mean, generally for the treatment of hyperkalemia, yes, but if you're in a cardiac arrest situation and you think they're hyperkalemic, I don't know that fluids are the sort of first indicated treatment for that
Mhm.
in a cardiac arrest situation. Because we're not talking about bringing down the K necessarily, but we're talking about giving treatments to stabilize.
Right.
I don't know. I didn't catch that in the adult version, but
So it's safe to remove it on both, is what you're suggesting?
that would be my recommendation, just because I think if you're thinking that in cardiac arrest, adding 2 treatments for hyperkalemia is probably not helpful.
Yeah. I would be supportive of removing the administer IV fluids and comments on both. Or I would just leave the word administer and delete everything after that.
Does the group concur for that change?
Sorry, Shelley, I couldn't hear you.
Does the group concur with that change on the previously approved guidelines?
Has anyone else approved with that minor edit on the previously approved guideline? So I'm not hearing any concerns.
I think just probably an official vote, since we're moving this forward. This is technically a public meeting. We're making edits, just probably an official vote with the change to the adult and then the pediatric one.
Okay. So all those in favor of removing IV fluids and on both the adult and pediatric cardiac arrest guidelines, say aye.
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 Any opposed? Okay, motion carries. So Shelley, leave the word administer after hyperkalemia, please. Thank you.
All right.
Okay. Any other changes to any other discussion to the pediatric less than eight cardiac arrest guideline as shown? Hearing none, all those in favor of approving the cardiac arrest pediatric less than age 8, say aye.
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 Any opposed? Any abstentions? The motion carries. Okay, we're on post-arrest care.
Okay, so for this one, I eliminated the line to avoid hyperoxygenation. These patients have a 50% chance of rearresting. And so I definitely think that just keeping them oxygenated is important. So I removed that. And then going down, there weren't a whole lot of other changes other than strengthening the shock treatment. So rather than saying if they're in shock, consider fluids, I think that the indication is to give everybody fluids who's in shock, post-resuscitation if they now have a pulse. So my recommendation is to strengthen the recommendation to treat shock. In our southern region, we sort of analyzed the post-resuscitation cases and very rarely gave adequate fluids or pressors with shock. So after significantly strengthening our stance on providing pressors, we've had much better compliance with keeping folks from becoming hypotensive before they reach the ED. So that's my recommendation here. We actually recommended hanging pressors on all patients in anticipation of shock, but that's not in the SEMSO.
Anyone have any comments on the changes as shown? Yeah, that looks good to me as well. All those in favor of accepting the post-cardiac arrest with the changes as shown, say aye.
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 Any opposed? Any abstentions? All right, the motion carries.
Obvious and apparent death. So this one, I thought it was interesting that we had exclusions for this. Because the obvious and apparent death lists things like decapitation or rigor mortis. So I felt like even if they had drowned but had been decapitated, I probably still think that it's okay. So I don't know. I don't know what others think. I wasn't sure why we had that as an exclusion here.
They're probably just pulled from the NASEMSO language, I think.
I don't know. I don't know if it came from our TOR guidelines or, I mean, because for termination of resuscitation, sure, you might exclude some of these, but for the obvious and apparent death criteria, I felt like we probably didn't need exclusions.
But do you recommend keeping a line about if it does not meet the criteria below, then refer to the other guidelines?
Oh, yeah. I think that's fine.
Yeah. Okay. Anything else below that?
No, I thought that was it.
Okay. Anybody else have any questions or comments on this page? Hearing none, all those in favor of accepting this minor change to the obvious apparent death guideline, say aye.
Aye.
All right, I heard one vote. Anyone else?
Aye.
Aye. Sorry, I forgot to take it off mute.
Any opposed? Any abstentions? All right, the motion carries. All right, do not resuscitate advanced directives.
Oh yeah, sorry. So this one, the only thing I changed was sort of clarified the verbiage here. I don't think we specifically listed the form as the pre-hospital medical care directive. So that's actually what the form is called. So I just put that in there. And I wasn't sure what the line I crossed out meant or why it was in there necessarily. It just says the interventions covered by this order and the details surround it and to implement them can vary widely.
Oh, that's in the wrong place.
Okay.
That should be under the MOLST, I believe.
Maybe.
And I think when we did this initially, the POLST was not necessarily approved in Arizona. That is now one of the advanced directives documents on the AG's website that people can upload. I don't know if we want to separate them out because they are a little bit different.
They are different, yeah. And I think the way that I've always explained it to our crews is that I don't know that they're required by statute to interpret them, which is not the case with the Orange Form. The Orange Form is sort of a pre-hospital order, and the rest of these are not, at least the way it was that I describe it, that they're not statutorily required to interpret these. They should call for medical direction to interpret them.
That is what the statute says.
So for that reason, I didn't combine anything.
And so I'm just looking at the Central Arizona guidelines as a reference, but that line about the interventions covered by this order details can vary widely. I mean, that seems to fit the definition of POLST and MOLST because they're patient specific and the circumstances are specific, whereas the Orange Form is more of a blanket, do not resuscitate with a respiratory component, intubation component, and a CPR component,
Right.
but
that
seems
makes
more
sense.
widely consistent. And
Right.
so I honestly can't tell the group where that line was meant to be. I don't know if it's just a typo that carried across multiple documents. If it's best to delete it or keep it on. I mean, it still makes sense to me to keep it under POLST and MOLST as is.
I don't have strong feelings about that line.
Are there any more substantive changes besides what we've looked at, Amber, on this page?
I don't think so.
So I don't want to steer the committee incorrectly on my previous comment. So is everybody comfortable with that edit that Shelley made of moving that variability sentence to where it's shown currently? Or does anyone feel strongly it should just be deleted? Is it helpful, not helpful?
Keep.
And you're happy where it is, moving it under the POLST and MOLST?
Yes.
All right. Anyone else have any comments on this? All right, hearing none. All those in favor of adopting the changes on the do not resuscitate advanced directives, healthcare power of attorney, say aye.
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 All those opposed? Abstentions? All right, the motion carries.
Franco, I have a possible go back. I'm sorry.
No
On
problem.
the post resuscitation one, I have a note that was in my comments that I forgot about the fluid boluses and it being listed currently as an AEMT, and whether or not we need to move that as an STR to EMT. I can't remember, or something needed to be moved. EMT is STR. There's something in here that might be an STR listed in the wrong section.
Is it
I'm just trying
the,
to- I don't know. No, I don't know where that comment was meant to be for.
Brian, can you help us out with
Oh,
that?
it was the end title CO2. I did move it up into the EMT section. I think we did move it, but it was it was previously listed, but it's not listed as an STR. And I don't know if that's necessary because that's sort of been our style.
Yeah. Gail, any thoughts on that?
I think for consistency, if we are, as we started to add the STRs, we should probably do that if that's an option.
Okay. So opening that back up to a vote again, all those in favor of including that STR comment back on the, what is this, post-arrest guideline?
Mm-hmm.
All those in favor, please say aye.
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 Any
Sorry
opposed?
about that. Totally forgot.
Any abstentions? Okay, the motion carries. Thank you. All right, we're at non-traumatic termination of resuscitation.
I don't think I had any comments on this one. It was beautiful.
All right, all those in favor of approving as is with no edits, say aye.
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 Any opposed? Abstentions? All right, that carries. Thank you.
Thank you, Amber.
Woo!
Wow, great. That's a lot. That's a lot, Amber, for one person, Amber. Thank you. All right, so this is my area here. So I've got my notes pulled up here. So this is patient refusals. Shelley, as I was looking at this just a moment ago, that first red EMCT, there's a typo there. That should EMCT.
All right.
So really, I was just changing some verbiage at the top just to make it read a little bit better. And then as a reminder to myself, the Central Arizona group took a good look at our refusal guideline just this month. And one sort of philosophical change we made was to change the entire title instead of patient refusals to read informed consent / non-transport / non-treatment. And really what that does is it sort of takes the adversarial tone out of the entire page as far as patients refusing care, when really what this comes down to is a proper informed consent process. And so that's something that I would bring to the table to carry over to this document as well. And that's why I changed that word from refuse treatment to decline treatment in the body of that second paragraph. I added injury as well because the initial was just specified illness. And then scrolling down to the EMT section. Just shortening up the wording to save space. Let's see. And then, yeah, so the stuff on the pediatric box was all basically just massaging the wording to read a little bit more clearly. And then I added that next bullet point after some discussion with Dale down in Tucson, who this is kind of an area of specialty of his in terms of abuse and neglect and suspected. At what point parents or guardians should not be the ones making a decision based on, for a minor, if the minor is thought to be in harm's way. And then at the very bottom, again, just some wordsmithing down there, and then added EMCT to make it consistent across the page. So nothing too controversial other than maybe the name change at the top, if anyone's got any feedback on that.
On that section where it says parents may refuse, in order to kind of going along with your terminology change, to do choose, or parent or guardian
Can decline.
can choose not to consent to care or something along that line.
Yeah, I just used the word decline, so we could change from refuse to decline.
Okay.
Can you repeat the updated title, please?
Yeah, so it's called informed consent / non-treatment / non-transport. Any other thoughts on this page? Hearing none, can we go ahead and move to a vote then? All those in favor of approving this new informed consent page, say aye.
Aye.
Any opposed? Abstentions? All right, the motion carries. All right, so for chest pain, let me get my notes pulled up here. For chest pain, so I took a look at the NASEMSO introductory language, and I thought it was pretty helpful. And really the areas where I thought ours had lacked a little bit was in being more specific about some ACS mimics. And so chest pain or I added back the discomfort in other parts of the body, non-specifics like nausea, vomiting, dizziness. And also I added specifically the sympathomimetic use stuff. That was something I thought was helpful, useful, and helped to be capture a little bit more of this patient population. The next section down there, caution. There's NASEMSO still hampers on the idea of being careful with other vasodilator medications, and they're also specifically inclusive of some medications, some of which I'd never heard of, but some medications for pulmonary hypertension. And also they move the flags out to 48 hours instead of 24. And so I added those in to just be consistent with NASEMSO. Then I added that bullet about immediately addressing cardiac arrest, tachycardia, and bradycardia with the intention of putting hyperlinks to those areas under EMT. I thought that would be easy enough to add in case somebody found themselves on the wrong page. Under the nitroglycerin, they took out there's no dose cap for nitro. So I removed the ×2. And then again, I added the pulmonary hypertension medications, and then again, pulled the transition out to 48 hours. Then for the sake of space, I just referred the reader to the nitroglycerin contraindications above under AEMT. I removed the cap of 2 doses. I added that and in between with the goals of pain resolution as well as blood pressure, the stability. And that's all I have for this page. In my personal notes, I think I may have forgotten to highlight it in red, but do you guys see under paramedic that second bullet that says location of infarct does not preclude use of nitroglycerin? I think that may be new. I think I just forgot to highlight it as a new change, but I have it in my notes that NASEMSO does not, or basically has moved to the evidence-based notion that nitroglycerin doesn't necessarily need to be contraindicated for people with changes in 2,3 and AVF, but they do emphasize monitoring hemodynamic status continuously. Any feedback on those changes?
Not on that one, but I do back up an EMT. Okay, in the 2019 scope of practice model at the EMT level, all references to self-administration of any medication has gone away. So just as a, that was in the 2007 version, but when there was a lot of discussion about that and they removed all patient-assisted medications. I think maybe it's not in ours anymore, in our drug box list where we used to list those. I think we removed them also.
So just remove everything that says assist to the word of and just start with nitroglycerin?
No, it's not in their scope.
It's not.
Nitroglycerin is not in their scope of practice either, but that concept of assisted patient medications has gone away.
I see. So then we would have to delete all of that and then somehow move it under AEMT, or at least to move those contraindication words under the AEMT section so that they're shown.
Yeah.
And also you'll have to, oh, never mind. I see it. Yeah.
So really that dash number 2 that starts with assist patient, that whole line can be removed.
So just for a point of clarification, unless I'm looking at an old one, it's still listed on the drug box as self-assist. It's authorized at the AEMT and it's 1 asterisk on self-assist.
So Josh, you're saying that it would be in scope to leave it under under EMT as a self-assist for nitro?
Yep. So again, assuming that I'm looking at the right one and I rely on Shelley or someone else from the DHS, nitroglycerin is approved within the scope of practice for AEMTs. And it has a single asterisk on it, which references at the top to authorized to assist in patient self-administration. And Brian, I realize that was removed from the national scope, but
Sorry, if I can interrupt, guys. Sorry, if I can interrupt real quick to just put a quick end to this. That was a administrative error that we caught that's on the MDC agenda for coming up in 2 weeks. That star was not updated when we fixed the drug table, so we did remove that from scope of practice when we voted. But we did not link back and remove that star. So I think Brian had brought that up a few meetings ago. So that is on the agenda for MDC to officially approve removing that, because that was a kind of a clerical error that we missed.
All righty.
Hey, and Franco, I just happened to pull up the EMT at the drug box. It still lists nitro sublingual as a potential under EMT scope of practice with asterisks that says authorized to assist in patient self-administration. So we still have it in the drug box that was approved last year this time.
Yeah, so that's what we're going to be updating in a
Oh,
couple
okay.
weeks. Yes. But we are at time, so I think we will probably have to, since we are still making edits to this one, start with this one at the next meeting.
Okay. All right. Then any other housekeeping items, Shelley, before I move to adjourn?
Are we needing to do another PMD meeting before November?
Shelley, we'll work offline on that.
All right.
Thank
I don't
you.
have it.
Okay. So then can I get a move to adjourn?
So moved, Brian.
Second? Anyone have a second?
Amber,
Yeah.
second.
All right. The meeting is adjourned at 3:01. Thank you, everyone.
Thanks.
Thank you, everybody.